that.
Yeah.
You got caught in a storm, or what is that? Your hair is
Yeah, and a storm of patience at ER.
Satish has up.
Namaste.
Namaste.
Hello, sir.
Namaste.
So
All
shall
right.
we-
So I don't
shall
know,
we
is
start?
anybody else joining us? I don't know.
I don't know either.
Yep. So we'll start. So and Florian and Dr. Dean. So as discussed last week, like we will try to present all cases. We'll try to be a little bit faster. And if we are too long in any case, you can interrupt at any time. We also want to improve on our presenting based on some time.
Yeah.
Okay. So that's
Perfect.
that's for all, for myself, Satish, Sanjay, and Vinay.
Perfect.
So I'll be sharing my screen. Okay? So can you see my screen?
Yeah. Yes, sir.
Okay. Mhm. I'll be showing my slides. So okay. So everyone, warm welcome in Global Vascular Conference Series 15. We'll be discussing about progress of the cases that were operated in in March 2023, and also be discussing one new case. So there we were happy to share that we could do 22 cases in main operating room with Dr. Florian and Dr. Dean and team. And so these were the different types of operation we did in the whole month of March. So brachiobasilic AV fistula we made four cases during that month, of which one we had already transposed and other will be transposing soon. And all the fistula are working as of follow-up till last week. And we did one case of brachial artery patchplasty and new brachiobasilic AV fistula creation, which was a very interesting case. And that fistula is also working, and will be doing transposition in few weeks. And we did one interposition PTFE graft placement, like 4 cases of interposed PTFE graft, and all cases are functioning till now. And 3 cases of brachiocephalic AV fistula creation, with all of them are functioning, and 3 transposition of brachiobasilic AV fistula was done, and 2 cases of proximalization of AV fistula were done, and all of them are doing good. And we did 1 case of ligation of radiocephalic AV fistula with dissection of stenotic segment of cephalic vein and new radiocephalic AV fistula creation with PTFE graft. So we don't have exact follow-up data of that patient. And we did 1 case of right femoral to SFA and profunda bypass, and 1 case of right femoral endarterectomy and femoral bypass. And this case we'll be discussing, and these 2 remaining cases also we'll be discussing today. And in terms of in cath lab, we did 1 fistulogram and ballooning, 2 cases of venogram with ballooning of central vein stenosis, 2 cases of tunnel cuff catheter insertion, and we did angiogram, 2 peripheral angiogram, and we saw 1 case in which we had made plans of doing bilateral common iliac artery ballooning. This case will also be discussed today. So going into the cases, first case, myself and Dr. Sanjay, we too will be discussing this case. This case is a 25 years male with CKD and hypertension under dialysis with left radiocephalic fistula created 3 years back in other center in Kathmandu. So currently he was referred to Dilkel with the problem of swelling of left hand and fingers since 3 months, blackish discoloration with non-healing also on dorsum of fingers, difficulty in movement of finger, normal sense. However, he had normal sensation, and right hand was as warm as left hand. So clinically, there was edematous left hand starting from elbow, and we could see aneurysmal dilatation of cephalic vein near the anastomosis site, dilated multiple branches of cephalic vein, especially in the dorsum of hand. All of the branches had good trill, and we could see multiple ulcers in dorsum of fingers, especially in the finger 2, 3, and 4. However, there was a normal capillary fill and good peripheral pulses. In ultrasonography, the most notable finding was there was stenos long segment cephalic vein in forearm, and there was like we could see in this picture, stenosis cephalic vein, and this is one of the dilated branch. So there were multiple dilated branches of cephalic veins, and all of them had high flow, and some calcification was also present in the fistula anastomotic site, and there was some subcutaneous edema. So Sanjay will continue with the
Okay.
plan and operative plans.
Thank you, sir. This case, we saw this case with the Dr. Florian and Dean in the last visit, and then we after the finding all those things, then we planned for the ligation of all that abnormal dilated branches with the resection of the stenotic segment of the cephalic vein and the interposition of the venous graft placement. But there was a little bit of improvisation at the time of operation that. We dissected the one main dilated branches from the dorsum of the hand, and we ligated all that other abnormal branches, and that main dilated branch of that cephalic vein from the dorsum is retrieved and swinged. Now you can see in this picture with the blue arrow, the after swinging of the main dilated branch from the dorsum after retrieving after the dissection, and then you can see the cephalic vein. This red arrow is showing the normal cephalic vein just proximal to the stenotic part, and then after that swinging, we perform the end-to-end anastomosis with that swinged branch of the dilated cephalic vein, which was retrieved from the dorsum of the hand, and then result was quite good. And this is the picture just after finishing the end-to-end anastomosis and the some repair saccular resection of that dilated sacculite dilated vein. And then this is the immediate post-operative period follow, and we discharged this patient after the marking for the dialysis. In the follow-up, the result was quite good. Dialysis is being done from the fistula. The swelling reduced markedly, and then again the venous ulcers healed, and the movement of finger was improved at the time of follow-up. Good trail over the fistula. But on the auscultation, there was a quite a bit unusual, like it's present in the anastomosis site plus in along, I think Brit is louder, and again I think more it's around 7 centimeters away from that anastomosis site. And in this is the picture with after the marking after and for the dialysis. Next picture, and the USC finding, that's USC finding seems good. And then in USC there are two problems. One is a small flap-like echogenic structures hanging at the site of end-to-end anastomosis, and probably falling, or and another is just narrowing of the swing vein around 7 centimeters away from the anastomosis site, at the same site where that sac-like dilatation is dissected and the repair with the proline. You can see in here the just a little bit of narrowing of that swing graft, and you can see the flap-like hanging structure at the site of the end-to-end anastomosis. There is some kind of problem is there, but fistula is again working, and the dialysis is being done. And then the concern is what can be done if that the stenosis just increase that along the that swing graft, and that's the our discussion.
Can we continue with the discussion, like Dr. Dean, Florian?
Yeah, that was the case we did, right?
Yeah.
So maybe like 3 days
Yeah.
before leaving, 3-4 days.
Yeah. So I remember that we did take as much vein from the dorsum of the hand as we could, but it was, yeah, we had to sort of pull it a little bit to create that anastomosis, right?
Yeah.
So it was slightly a little bit tight, but you know, I think the result is, as you described it, is very, very good. And as long as the fistula is working, I wouldn't actually do anything. And as soon, I mean, you have to survey him and ask the dialysis guys. And as soon as there's a problem coming up, like there's an insufficient fistula flow, then I mean, what you can do is very easily to just to find that location where the stenosis is, and then do a patchplasty there. So, but I would wait with that, you know, so that all the scar tissue is healed and that they can puncture along the whole fistula, and then, well, if necessary, you just do a little patchplasty there. That's all I would do.
Yes. So, yeah, thank you. So, Dr. Dean, any comments?
Yeah, I guess that little flap that's in there's probably a valve leaflet. I wouldn't worry about that at all. And Florian's right. If it's working well, you don't have to do anything. Some people would patch that now. Some people would wait. Most often, we probably wait, because most often we don't even know that a stenosis like that is even in there, unless there's troubles with the dialysis. So,
Yes.
good, Florian.
Yes, thank you, Dr. Dean. So, so regarding case 2, like this, only show the picture. Like we had a very similar case in a female patient, and that patient has also come for follow, and the fistula is working good. And we have marked the site where we can cannulate it, and this is also working fine.
How does her hand look? Do you have a picture of her hand now?
So, like, sadly, like, she didn't come for multiple follow-ups. Like, but the time when we saw in OPD, we forgot to take the pictures. But the color and swelling has decreased, and the color is also much better.
And you know that because of a phone call, or just that?
No, she came to
That's the way
OPD.
it was.
We saw her once in OPD. That at that time also it was already the swelling started to decrease and the color was better. And after that,
I think
once we contacted phone also.
I think she came to OPD at once, I think, and only for the suture removal.
Yeah.
So
So if I make it,
we missed her to take a picture. So
yeah,
on one.
I would strongly recommend to try to track her down again and take a picture, because those two cases, I think we talked about them already, are really good and interesting cases, and you have a very nice follow up. Then if you take a picture, you have
So
intra and post operatively, and those are really good cases. I also like the drawing you did in the last in the first case. You know, is very good actually.
yeah, so I just take the time, the free time I utilize to draw it. So yeah.
So, smart son.
Dr. Dean and Dr. Florian, I have talked with Dr. Nobin. She's on regular follow-up with Dr. Nobin. We can take a picture if we want and send it to you guys.
Yeah,
well, yeah, but it's for you mostly. It's because those two cases are really interesting cases. If I had those two cases coming within a week, I think I would be thrilled. You know, it's amazing. I've never seen that. You know, and then we have them within 3 days.
And the patient is also happy with her hand, and she's doing dialysis on a regular basis.
So these two cases, Florian and Dr. Dean, so we'll definitely be writing, and we'll try to document as much as we can.
Well, right. I think these two, you know, I know you write up a number of case presentations. These two are actually pretty interesting.
Yeah.
Rare. I mean, I'm not sure as I've ever done one of these at home here. I can't recall actually. I mean, yes, you get some with outflow stenosis and you do bypasses, but not that present ever with such hand swelling like that.
That's great. So definitely, okay, we'll start writing very soon. So we'll go with the case 3. So Binay will be presenting 2 cases, case 3 and 4. So over to you, Binay.
Hello everyone. I'll be presenting about the 2 cases of peripheral artery disease, and both of them went through a femoral bypass. One of them was femoral to profunda bypass, another was femoral to femoral bypass. Both of the cases were done on the same day, and one case went very good, one case didn't went that good. Next slide. So the first case was Mr. Durvani Upani. He was a 45 years male who complained of resting pain since last 1 month. So Florian and I, we were in OPD when he presented to us, and he had been counseled by folks at teaching hospital Maharajganj that he needs to go amputation, and nothing can be done about the resting leg pain. And as you can see in this figure, there is complete non-opacification of left common iliac artery, and with some hint of profunda system and some collaterals. So we knew that the thing might not work at all, but still, on the request of the patient and for avoiding amputation as much as possible, we attempted to undergo the patient with right femoral to left profunda bypass. The patient went right femoral to femoral profunda bypass, and even in the post-operative period, he still complained of resting pain. And after 1 week of post-operative period, we discharged him, and he followed up with us in 2 weeks, and it had not healed at all. His resting pain was still present, and he was still in pain. So it was during the last days when Florian and Dean were about to return to their countries. So we counseled him about the need of amputation, and later on he underwent amputation, a below knee amputation. And as expected, because of the femoral to profunda bypass, we were expecting the wound healing would be good. And he followed up with us 3 weeks after, sorry, 2 weeks after the amputation, and his below knee amputation wound was really healthy. There was no discharge. There is no site of infection or pus. And remembering Dr. Dean's advice, it's better to keep suture for a long period of time than to cut early. So we counseled him to keep sutures for around 1 month, and he will be following us up in coming weeks. So this case did not go that good initially, but later on, after amputation, he's now feeling fine. He does not complain of much pain. So although for now he's wheelchair bound, he is undergoing extensive physiotherapy, and we expect his life to be pain free. The fourth case.
Bine, can we just comment on that case?
Yeah.
Now, my question is, do you think what we did was okay, or was it reasonable? Or did it have a good effect, or was it just bad? What do you think, or you all?
From the beginning, we knew that the outcome might not be as dramatic as we expected, and we didn't even expect that much of a dramatic change. But we somehow wanted to activate his already present collateral systems, and I believe that it worked to some extent. That his below knee amputation wound is healing and is not got infected. So for that, I think it worked, because we took a 12 to 13 centimeter stump below knee, which is quite long, and he will be using the false what we call limb, and he can walk with that. So I think overall the outcomes is fine and acceptable.
Yeah, definitely. I would say so too. So the idea behind it was that we want to try, as you said, to ignite, so to speak, the collateral system, and that worked to a certain extent. It didn't work in terms of that we could salvage the limb, but as you said, I mean, it was a below knee amputation, and that is much better than an above knee amputation.
Yeah.
And maybe this would not have been possible if it hadn't been for the crossover bypass. So overall, it's quite okay. It was not very bad. That's what I, and it was reasonable thinking, a reasonable case discussion beforehand, and weighing the pros and cons. And I think in the end, it was better for the patient to do that fem-fem bypass than not doing it.
Yeah. Any comments by Dr. Dean?
So, Benet, seeing as how we're working on short answers, the answer to Florian's question quickly would have been, yes, it was worth doing. You basically kind of reset everything, okay?
Oh yeah.
Now,
yeah, definitely.
so if he comes in a week or 2 or a month or 6 months, and he's complaining of pain in his stump, now what are you going to do?
First, I will inspect on the incision site. Has it healed completely, or he has developed some kind of stump ulcer, or things like that? And
Well, let's say it's cold. Let's say the stump is cold now. Now what are you gonna do?
so if a stump is cold, I would suspect there is some kind of ischemia going around into the remaining vasculature that he has in the stump. So initially, like by the time he comes, he will already be in conservative management, like some antiplatelets. And if it does not improve even with that, we need to figure out what is the vascular status to his stump. So try to pick up some collateral vessels through USG, and if I cannot find them, maybe angiogram.
So what most likely is the problem?
So persistent stenosis, maybe he's still smoking. We need to ask him that.
No, his bypass clotted.
The graft has been.
Okay.
Most likely. So what you should be doing is feeling his femoral pulses.
Yeah, sure.
All right. Which then sometimes you can go in and clean out the clot out of the bypass. All right. Okay.
Okay.
So that's the additional teaching point there.
Yeah, thank you.
Thank you, Dr. Dean. So Satish,
How can we just clean? Just asking, just wondering, how can we clean the bypass? We can go the like embolectomy, Fogarty.
Well, you pass Fogarty catheters. You probably would explore it. Well, you could get a pre-op angiogram, and you probably would explore it at the left femoral area to pull clot from the graft, and also make sure that you pass catheters down as profunda to get out as much clot as you can. Florian, what do you think?
I don't think that I would do another angiography. If it's occluded, then you can see it by USG or by just not feel the pulses, and the proof would be USG. And then what I usually do in that case, I don't reopen the wound, I don't go into the scar tissue, but I just make a little incision right above the bypass, and then because it's subcutaneously placed, and then just do a little embolectomy, as you said.
Just above the pubic symphysis.
Just over the bypass. Yeah.
Okay.
yes, thank you.
The key teaching point is if it comes in cold, the bypass most likely clotted. Okay. And then you do it, and then you try to do an embolectomy.
Yes, so we need to continue with the case program.
This is the second case of peripheral artery disease who underwent femoral bypass. He was a 65 years male who complained of claudications and since last few months, and the claudication was just progressive in nature and was becoming worse and worse. And he presented to us, and he was a suitable case for a femoral bypass. He underwent a femoral bypass during March before we went out for the trek. But one complication that arose the very next day of the very first post-operative day was that he developed a fall in the post-op ward while mobilizing or going towards the loo. And following the fall, he complained of pain and swelling around the incision site. And on examination, there was a large hematoma in bilateral inguinal region. And immediately the case was shifted to OT, and the incision was reopened, and a small area of leakage was identified, and the leakage was closed. And by the time the OT was done, his hemoglobin has fallen down significantly. So he underwent a impressive post-operative resuscitations with IV fluid and blood transfusions. But eventually, by the time of his discharge on his 8th post-operative day, he was feeling good. And we asked him to follow up on 3 weeks later. And at the time of follow-up, 3 weeks later, he was fully mobilizing on his own. And surprisingly, he had no claudications even after walking for 10 to 15 minutes, which was very much dramatical for the patient, and he was happy. And one important thing is that he was not an active smoker by now. He had quit smoking. So even the second case, although the intraoperative and postoperative period was sort of involved with jerks of complications, but eventually the case went well, and now he is pain-free.
I recall that we weren't quite sure what actually happened during early post-operative stage, right? Because
Yeah.
very small, there was basically no blood, as you said, found inside the wound. So and he had a huge hematoma, subcutaneous hematoma, right?
Yeah.
So what is the teaching point? Maybe just try to well, on the ward, post-operatively, patients should not leave their bed on their own the first post-operative day. I mean, they can be like weak from the anesthesia. Maybe they have pain, so they stumble, so they fall, and I think that was actually the main problem. I don't think that he, as he described it, that he really had a severe leakage.
Not much.
Yeah.
But otherwise, very nice. Do you actually have the angiography from beforehand? I don't remember that one.
I think we need to look.
For this
Okay,
case,
well,
we didn't include, but
if you don't have it,
Sure. Actually, this is the case that we have been continuously following this case. The angiography is, I don't think we have a proper picture of that, because that day the patient presented with the severe progression of that, the claudication, and then the Dr. Sir Florian, sir, you performed that USG and you immediately planned for the bypass. So I think we don't have the proper angiography. I think.
No. We have the angiography. This patient underwent a peripheral angiogram and conventional CT angiogram beforehand, and we have I think conventional peripheral angiogram in cath lab. We can have that picture.
well, I was just wondering. I mean, obviously everything is good, and now that he's happy means that his leg is now profoundly reperfused, which is good. So I was just being curious, nothing else. So you don't actually have to look them up and find. So I'm just happy, and it's good for the patient too.
so can we proceed to case 5? Last. So Dr. Satish will be presenting the last case.
So this is the last case. I think Dr. Florian, Dr. Dean, Dr. Robin, and all of us saw this case. This is a 58 years male, Mr. Adhikari from Kathmandu, presented with a bilateral claudication since last 6 months, with more on the right side than on the left side. And on examination, there was a bilateral femoral pulse was palpable. However, the distal pulse was not palpable on both limbs. We did after this we did an Doppler ultrasonography and ABI. On ABI, on both sides there was no findings and the ABI was 0. And on the Doppler ultrasonography, the left CFA was triphasic flow. However, right side there was monophasic flow. And on bilateral popliteal, there was monophasic flow, and pleural vessel there was no flow detected. So CT angiogram was already patient had already done a CT angiogram. So on CT angiogram, it showed there was a long segment of opacification on the right common iliac just below the bifurcation, and the flow was noted in the common femoral and profunda. However, there was a long segment opacification in the left superficial femoral artery to P1. Sorry, we didn't have a picture. So we did, after discussing with Dr. Florian and Dr. Dean, we planned for a conventional angiogram, and as both of you suggested for a kissing ballooning, so we did an angiogram. First angiogram showed there was a complete non-opacification of the right common iliac artery, which was about 4.6 centimeter long segment. On the left side, similarly, there was a CFA was 7 centimeter long segment stenos, and the right popliteal and the left popliteal was opacified, and the left popliteal was non-opacified, and bilateral pleural vessels there was no flow. As we can see, these are the picture of both right and left limb. We can see small flow present, a few flow present on the right side, and the flow present from the P1 and below on the left side. So these are the pictures of the angiogram. We inserted a catheter from both the common femoral artery, and from the both side, we try to dilate 6 mm balloon simultaneously, as we know as a kissing balloon. In this picture, we can see there is a kissing balloon which we dilated multiple times, I think 3 times. Post ballooning, a left side has a significant increase in the flow. However, there on the right side, we did not notice any flow, any changes. Next slide. So on follow-up, the patient, like last week, the patient came and the patient has a similar claudication on the right side, which is more less than 3 minutes. But on the left side, the claudication has improved. It is about more than 10 minutes. Now the left CFA stenosis has been treated. Can he now be planned for a fem bypass, or any other things can be done to for the right side stenosis?
What would you do?
Since the claudication is less than 3 minutes, so we have to intervene this patient to prevent the limb. So I think as there is no flow on the left side below the superficial femoral artery, if we do a fem bypass, then the flow might get hampered on the left side also. So I think we should plan for a right-sided aorto iliac or aortofemoral bypass. And then if it is good flow below on the right side, if left side is also a problem, then we can go for a fem.
Just a technical question. You have a 15 millimeter balloon and a 4 millimeter. What is the 4 millimeter
diameter? We don't have a very big diameter balloons. So 15
But that's,
millimeter
you don't have what? You don't have a?
much bigger size balloons.
Yeah, what is it? Is it a 15 millimeter in length and 4 millimeter?
4 millimeter is diameter and 15 millimeter is length.
Okay, so you did a ballooning of 4 millimeters in the iliac artery, and the iliac artery usually has a caliber of 8, 9 millimeters, a centimeter. Now you open it to 4 millimeters, and now if you do a fem, it means that those 4 millimeters have to perfuse 2 legs.
Yeah.
I find the idea pretty difficult. You know, you could do it if you had ballooned it, well, 8 or 9 millimeters plus put a stent in to make sure that this really remains patent and has a good inflow. Now, this is, I think, okay for the situation on the left leg, but it's, I don't think, enough for feeding a fem. So 2 legs. That's
so,
yeah. And the second thing is, I find the definition of walking distance of less than 3 minutes is needs reperfusioning. Needs reperfuse. Was it reperfuse? Well, yeah. Well, however, you know what I mean. Usually we say, is it critical or is it non-critical? If it's critical, if it's non-critical, we don't actually need necessarily a reperfusion. But critical and non-critical is differentiated by rest pain and also or not. And if they don't have rest pain, so if it's only a claudication, then we don't necessarily need a reperfusion.
So on the right side, on the both limb, the patient does not have a rest pain, but as he walks, he has a pain on the right side after within 3 minutes. He said like that.
Yeah. So the problem is 3 minutes is this is not a definition that we actually have in PAD. You know, we define walking distance according to, like, is it how fast do they walk and the if they walk a little bit up or something like that, they have certain angle. This is defined by the guidelines, but it's not the walking distance measured in minutes. Now, the thing is, if you create a fem and then have an incompetent inflow, then you hamper both legs, maybe, you know. So in that case, if he was here, well, we would go for a, well, as I said, ballooning plus a stent, and then do a fem-fem, or do an aorta bifemoral. Now, there's just one thing I wonder. The picture on the right seems to be much wider than 4 millimeters. So how is that? Is that just a